Well, welcome everybody. This is a hybrid session, so we have speakers here in person, some audience in person, as well as online. My name is Paul Wise. I'm a professor of pediatrics in the med school and a senior fellow here at FSI. And I have the privilege of introducing our two speakers today and moderating the discussion. I will be checking the chat online to ensure that questions that are coming from our online participants are represented in the discussion. Over the past several decades, global health threats like HIV and pandemics like the Ebola pandemic and now COVID have been securitized, increasingly framed as being national security threats. While this frame has had some utility, it has also been questioned as potentially inappropriate by characterizing what has long been viewed as health or humanitarian challenges as issues of national security and potentially diverting funds towards what has been viewed as national security, health and humanitarian threats, and diverting it away from issues such as chronic disease, malaria, or child malnutrition. We have two experts with us today who are going to help us explore this issue. First, we have Dr. Sigrid Lupieri, who holds a PhD in developmental sciences and two masters in history and in journalism. Her research has focused on how security concerns and foreign policy agendas have shaped humanitarian action, particularly in the Middle East, with a special interest in Syrian refugee crisis in Jordan. She also has considerable expertise as a journalist, has worked with the UN in settings around the world. Also with us today is Dr. Frances Butcher, a pre-doctoral fellow at CSAC and a PhD candidate at the University of Oxford Ethics Center and the Wellcome Center for Ethics and Humanities. She is a physician with public health and clinical research training. She also holds two master's degrees. Some of us with just one master's degree is feeling very much inferiority complex after this. Master's degree in bioethics and society and global health sciences. She was also a 2019 fellow in the Hopkins Emerging Leaders in Biosecurity program. It's a privilege to introduce them both today and look forward to the discussion.
Well, thank you so much. I am really excited to be here on this panel, which just so happens to be particularly timely, especially in light of the COVID-19 pandemic. And to be talking a little bit about the research that I've been working on over the past year while here at CSAC, and especially on a small part of my research, which I'm planning on expanding and is very much research in progress, which looks at the increasing securitization of health issues in humanitarian settings and what this actually, what kind of implications this ultimately has for the allocation. So this is part of a larger book project. Just very briefly, the book project focuses on the politics of distribution in humanitarian settings. And I base my research on the Syrian refugee crisis and its response in Jordan, in particular to health, and look at why is it, for instance, that certain refugee populations, for example, say women and children, are prioritized within healthcare responses, often at the expense of the needs of, say, young men or older people or people with disabilities. And from a health perspective, which is more closely tied to what I'm going to be presenting today, why is it, for instance, that some diseases, in particular infectious diseases, are being prioritized, even though non-communicable diseases or chronic diseases such as hypertension, diabetes, and cancer actually cause the vast majority of deaths worldwide and also in certain humanitarian settings. So just very briefly to outline what I'm going to be talking about today, I'm going to talk very briefly about the concepts, particular health as a security issue, and also look at my understanding of how health is being increasingly securitized and kind of look at the perspective that I take within my research. Then I'll go straight into my case study, the Syrian refugee response, or rather the medical humanitarian response in Jordan, and briefly touch upon some of the implications of the securitization of health and of the allocation of resources for the medical humanitarian response as a whole. So first of all, when we talk about health and national security, we have seen that the interlinkages between health and security as a state, as a national security issue have been increasing over the past couple of decades. But even just in recent history, we just have to look at, for example, the Ebola crisis in West Africa, for instance, to see how diseases do have relatively clear, especially infectious diseases, have clear interlinkages with security issues. For example, they can affect and incapacitate the military. Health issues can have long-term economic impacts. And for example, during COVID-19 and during lockdowns, we've seen how health issues can also spark riots, protests, and civil unrest. The issue of security in general over the last couple of decades has also, the concept has also undergone an expansion, and that we're not only looking at threats to the state, but also understanding security, for instance, as human security and as potential threat to human survival and to mostly to survival. So recent examples, for instance, are the war in Syria, in Yemen, in Afghanistan, and we've seen this in Ukraine as well, where hospitals and medical professionals are specifically being targeted during conflict. And according to some reports, approximately 50 to 70% of deaths are related to indirect deaths beyond the conflict of people who, for instance, cannot access medical care because hospitals have been targeted and medical health professionals have fled. The debates that I mostly engage in have to do with critical security studies. These have emerged over the past 20 years, mostly in Europe, and take a more critical approach to understanding when does an issue become securitized. And the way I look at it is mostly from a discourse, speech analysis perspective, in that we see how securitization is very much an intersubjective understanding. So for instance, you take an issue like migration or refugees, which was perhaps previously not securitized. And when policymakers and politicians begin to perceive it and to address the issue as a state security issue, then it becomes securitized. And when it then further brings about policy shifts, for example, funding and emergency responses, then we consider the issue to be fully securitized. So this understanding has been applied more recently to health and healthcare. And scholars have begun to observe how when we securitize infectious diseases, this leads to a huge amount of funding going to infectious diseases over, for example, chronic and non-communicable diseases. And I think one of the really interesting quotes that I've come across in the literature is from Christian Innemark, and he really describes this, and I think this is particularly relevant during the COVID-19 pandemic. He says that the best candidates for securitization are those infectious disease threats that inspire particular human dread and which therefore generate a level of societal disruption disproportionate to the morbidity and mortality burden they pose. So how does this actually translate into global health and global trends? I think this particular figure is really informative in terms of seeing, first of all, how financing of global health has dramatically increased over the past couple of decades. We see that global financing for development assistance for health has gone from about $7 billion in 1990 to an unprecedented $55 billion in 2020, especially during the COVID-19 worldwide response. And more interesting, the second point that I want to point out is if we look at the orange bar, which shows the proportion of funding that is going towards infectious diseases. And if we also look at the blue bar, which looks, for example, at HIV/AIDS, another infectious disease, or tuberculosis, we see that the vast majority of funding is going towards these kinds of diseases. And if you look at the legend, non-communicable diseases are actually not even mentioned within this funding overview. So now I'm going to move on to the case study. What have I seen? What is happening within the Syrian refugee response in Jordan? So first of all, there are approximately 670,000 registered refugees in Jordan, that is refugees registered with UNHCR. The majority of these have begun arriving around 2013 and 2014. As you see, Jordan has a relatively large border with Syria. And to date, they're still mostly residing in the country, even almost a decade since the beginning of the crisis. And about 80% of these refugees live in host communities. Just really briefly to outline my methods, it's mostly based on semi-structured interviews with key informants, along with participant observation. I spent about 4 months with an international organization, and as well as an analysis of the main policy documents that have emerged from the humanitarian sphere, but have also been published by the Jordanian government throughout the humanitarian response, as well as obviously the statistics that have been produced. So when we look at what are the actual healthcare needs of Syrian refugees in Jordan, it is actually really, really hard to come by this data. But what we do know is that across Jordan, non-communicable diseases cause approximately 80% of deaths. And we also know that before the conflict in Syria, cancer was the second leading cause of death. So we can surmise that that is still a very high burden of disease among the Syrian population today. But it wasn't until 2015 that an MSF report came out stating that most of the funding was going towards infectious diseases, but actually chronic illnesses are killing just as many people as our bullets and bombs in Syria and in neighboring countries. And yet, if we look at donor priorities in Jordan, and donors are mostly government bodies, but also UN agencies that provide most of the funding for the healthcare response, most of the priorities are still in 2018 and in 2021 on emergency health, on ambulance care, hospital services, on camp services in refugee camps. And if we look at the language, it's very much focused on life-saving, life-changing, and again, life-saving procedures. And there is, of course, a certain amount that is also going towards gender-based violence and sexual and reproductive health services. So just to give you an example to really understand what is going on, if you are a Syrian refugee in Jordan and you have, for instance, a chronic disease or a disease that is considered expensive to treat, what are your options? And there's not a lot of options, obviously. So first of all, there is a cap on annual expenditures, which is approximately $2,000 per person. And if you have, for instance, breast cancer and you need treatment, that's going to cost approximately $35,000 as a rough estimate. So once you've spent your $2,000 yearly limit, what you can do is appeal to one of UNHCR's exceptional care committees, which meet approximately once a month, and decide whether or not to allocate additional resources on a case-by-case basis. And this very much depends on your prognosis, so your chances of survival. If you have good chances of survival, then chances are higher that you're actually going to get the additional $12,000. But even if you get the $12,000, of course, there's this massive gap between what you're actually going to need to deal with your health issue and what you're actually getting from the humanitarian system. So it comes as no surprise that the majority of refugees with chronic conditions say that they cannot get the care that they need. And I think one particularly compelling quote that came that I heard during an interview with a health professional working at an NGO in Amman, really related to this issue of breast cancer. She was saying, what is the benefit of doing breast cancer screening and awareness raising? And when the lady or the old man comes and I find a lump in the breast, what do? I cannot offer any management beyond that. And so now I'm going to briefly just outline my findings. And why is it that we see this massive discrepancy between what are the actual needs in the field and what is happening in terms of funding and in terms of the healthcare response? And the first part of the answer is maybe the most obvious one, in that, as everybody can imagine, donors are very much intent on cutting costs. What is particularly interesting is that we're seeing this kind of language, these kind of market-driven logics infiltrating the humanitarian response in terms of looking at investment, how to invest money, and how to get a return on investment, even when talking about healthcare. So when you decide whether to allocate resources if you're a donor, people in the field are saying, well, for example, if it's a 5-year project, the donor will not invest, for instance, in older people who are 70 or 75, because they know that in 5 years they will die or something might happen to them. So they invest their money in children or younger generations so they can eventually, the implied part is that they will return to the job market and they will eventually bring about a return on this investment. So we're seeing how older people and people who are more likely to have chronic diseases and non-communicable diseases are very much being cut out of the humanitarian response. And generally, there is a resistance to supporting diseases that are considered chronic or expensive. As one donor told me quite dispassionately, you shouldn't even provide screening for cancer if you can't provide treatment. Who will pick up the chemo tab? And the answer to that is obviously relatively complicated. A second issue that came up that was relatively surprising in my research and I wasn't really expecting was that many of the healthcare professionals that are working in Jordan have actually years, if not decades of experience working in different settings in sub-Saharan Africa, where everything is mostly focused on acute care and emergency medicine and where there is no infrastructure. And a lot of the medical professionals stated that they were really surprised that they were in a middle income country and they were having to deal with a completely different set of problems and diseases and population makeup, which they were not expecting. And I think one of the quotes that was most compelling was from this UN health professional who said, I do remember from 10 years back when I was with MSF working in Iraq with our standard drugs and packages, people were upset. They said, go away with your rubbish African healthcare standards here. Iraq had some of the best universities and some of the best trained doctors, and it's the same here in Jordan. So there's very much a sense of actually Syrian refugees have very different expectations as well. And we can see here how even 10 or 20 years later, after the crisis in Iraq, the humanitarian system has been very slow to respond and adapt its priorities. And last but not least, we come to the issue of security. And this was also one of the main themes that emerged when I was conducting my interviews and very much reflects some of the global trends that we've been seeing so far, especially since the COVID-19 pandemic. First of all, we see that a lot of donors are particularly worried about infectious diseases that can cross borders. And there's very much the conflation of refugees as carriers of illness and disease. And the idea that they could be bringing diseases, for example, antimicrobial resistance, and that these could then eventually create a new epidemic or a new pandemic. And as another donor said, TB, so tuberculosis and communicable diseases still get us out of bed. And here again, the issue of aging came into play, but older people do not spread communicable diseases. They're largely immobile. So there's really this conflation between international mobility and diseases crossing borders. And then, of course, from the perspective of the Jordanian government, there's very much the idea that you need to protect the national population from the spread of diseases, which is often conflated also with the risk or the perceived risk that refugees bring of, for instance, terrorism or potentially popular uprisings and civic unrest. And here we see how in one of the speeches by King Abdullah in the last paragraph, he sees the Syria crisis, the refugees, as posing an increasing threat to human security, development, and economic growth. So we see this constant expansion of the idea of what is security and what kind of effects can it have. And now I'm going to conclude. I wanted to just leave you with this picture of the Zaatari, the sprawling Zaatari refugee camp in Jordan, which houses about 120,000 Syrian refugees. 10 years since the beginning of the crisis, a lot of things have not really changed in terms of the priorities of the healthcare response. And we have seen how an immediate emergency has over time turned into a protected crisis. And one of the big takeaways is that when we keep looking at health as increasingly as a security issue, then really what happens is that everything becomes an emergency, and everything only becomes focused on emergency responses and responses to acute care, without focusing on actual burdens of disease, such as non-communicable diseases, and without focusing then on what happens in a protracted crisis, which ends up being the majority of refugee crises in the world today. And that's it on my end. I'll now pass on to the next presentation, which will deal a bit with the moral and ethical implications of this aspect.
Okay, thank you so much for being here. So I'm going to follow on from Sigrid and almost present the counterfactual to her presentation. So she's very eloquently described around the implications of securitizing infectious diseases on non-communicable diseases. But now I'm going to ask the opposite and say, should global health security be expanded beyond epidemics? And just to say that this is a work in progress and it's ongoing work for my PhD. So to give you some background to this, we've heard how strong this connection is between epidemics, which I define as infectious diseases that have a risk of crossing over state boundaries, to how common these are framed as global health security problems. But recently, in the last few years, there's been a small but growing body of academic literature that has expanded this concept to other areas of health, most notably non-communicable diseases, things like diabetes and cardiovascular disease, but also aspects such as universal health coverage and health system strengthening. And at the same time, we've seen some counter arguments to this. I think a particularly strong paper comes from Claire Wenham on the over-securitization of global health, where she lists the almost ridiculous amounts of health and related conditions that are now seen as global health security problems, from maternal health, counterfeit medicines, salty foods, even Brexit, which is one bit closer to the heart for me. And she argues that whilst at the human level, all these may lead to individual insecurity, it seems a real overstretch here that these are all part of this global security agenda. And this is a perspective I can largely agree with. But when I was doing empirical work for my PhD, this expansion of global health security kept coming up. So I wanted to explore why those that actually work in the field, that work in global health security policy, that work in projects for this, are advocating for this. And the methods by which I do are qualitative bioethics. And today I'm going to be focusing on preliminary results from the empirical data, which is in-depth semi-structured interviews with professionals in the field. So those working at a quite high kind of national, international policy level, as well as those that work on specific global health security projects, and those that work in related disciplines, so infectious disease, response and prevention, that wouldn't classify themselves in this field. So in this talk, I've got three aims. So I want to convince you, first of all, that this argument about the expansion of global health security isn't just a theoretical one. This is actually one that's being discussed and debated within the field. And that there are three key arguments of which have some ethical or moral dimensions for this expansion. But I'm going to conclude that we should not focus on expanding the concept, but that these arguments identify really important issues that need to be addressed. So first of all, I just want to demonstrate that this is an argument that's being made. We should expand global health security. And this was an argument made, not in all of my participants by a long way, but in a significant minority. And I'm just going to read this quote from one of them, because I think it really nicely encapsulates this view. So they say, and this was a European professional in global health security or infectious diseases. So they say, I take a very broad perspective, which is that global health security threats can really be anything that affects our health that can cross borders. And so that is anything from an infectious disease, which I think is what most people tend to think about, to climate change. It can be the action of transnational, multinational companies and what effect they might have on us. This is a view, for example, that tobacco is a global health security threat, that the actual global international tobacco companies, because of the way that they strategically try and damage health in a way that crosses borders, that is a global health security threat. So I think this clearly shows this perspective that global health security is about more than just infectious diseases for some of those working within it. So next, because I'm interested in ethics, what I'm interested in is the arguments that people make for these perspectives. So next, I'm going to present 3 arguments that I've identified from my empirical data about this. So the first argument I want to talk about is the moral rejection of global health security. And I'll start with a quote again that summarizes this. So this participant says, the idea underpinning global health security is set up to benefit a small number of very wealthy Western influential countries. Global health security is about us, the West, being protected from them, the global South, rather than a global protection system. And I'm just going to summarize the commonalities between this perspectives like this into an argument form. So the argument here goes, the focus of global health security is ethically problematic because it's only about infectious disease outbreaks that affect the West that are seen as security problems. And therefore, we should expand the concept to include concerns of the global South, whether that's infectious diseases that are not securitized, it's very much not uniformly all infectious diseases that are of interest here, or indeed non-communicable diseases. And you'll see here that this is a really strong negative argument. It's not about what global health security should be and should mean, it's about actually what it should not be. And for anyone that's ever kind of looked at global health in any form, this will be familiar to you. It's similar arguments that have been made against global health, international health 25 years ago, that it's all about a particular focus. And so I think this is a really important, a really kind of strong ethical argument that could have implications for the field and how stakeholders engage with global health security. But the problem here is, I think that therefore we should expand it is a slightly flawed solution, because this doesn't necessarily solve the ethical concerns. If the ethical concerns were just, it's these infectious diseases and not these areas, this argument would solve it. But I don't think this takes into account the structure and the methods by which global health security functions, by which there are also concerns about. And if you think about it as well, it's also a somewhat of a bizarre argument, because if you're saying this enterprise has significant ethical problems, the solution to expand that without checks on how that would function is, it just seems a little bizarre. So next, I'll move on to the argument about enabling a collective response. And again, I'll read a quote to start out. So this participant says, that is part of the global health security definition, global warming, in the sense that it's likely to have effects across the globe and would need collaborative, joined up approaches. And then again, to summarize how this argument functions through the different interviews. So this would go, epidemic diseases necessitate a collective response. The global health security framing enables this collective response by raising problems up the international agenda. Other global health problems would also be benefited by collective response, and therefore securitizing other problems would be beneficial. But I think this, again, has some problems. The first is a simple empirical one, that it's aspirational that global health security problems lead to collective responses, but actually that doesn't really happen in reality. We've all seen through COVID the calls for collective responses, the calls for solidarity, but that is far from actually what happens. And also, I think there's a conceptual flaw here, which is that the features that require a collective response are being equated with the features that lead to securitization. And I don't think that's the case. I think Sigrid really nicely demonstrated that in that whether rightly or wrongly, the features that have led to successful securitization around urgency and that perceived threat to us, which is just a lot harder argument to make if you're, say, talking about diabetes. And then the third argument about why we should expand this definition of global health security is about the artificial separation between global health and global health security. And I've got a quote here that's about a particular incident a participant found troubling. So they say, a few years ago, whilst working in a West African country, we were doing a scoping mission, and I had cause to meet the director of the polio vaccine campaign. And he made a comment about, how frustrated he is that he can go to all this elaborate effort to get polio vaccine to these remote areas and cannot at the same time get meningococcal disease vaccine out or measles vaccine. So here you have one securitized disease, polio, for which the efforts involved massive use of resources, military, remote health workers, to get this polio vaccine out. But because meningitis and measles were seen as more routine diseases, they couldn't at the same time, despite having capacity, just stick those extra vaccines in the fridge. And so the argument here goes that separating global health security problems from other health problems is an artificial divide, which leads to inefficiencies. And this is a really strong argument. It's very difficult to say that this is not true. But the problem with it is that this is an argument we can make about many disciplines. And if we allow this argument to function, all of global health essentially becomes global health security, which the risk is that it weakens the credibility of advocates arguing for the security resources for health for those large-scale, devastating biological threats. So from these arguments, I'm now just going to go into my conclusion, and I will emphasize that as this is a work in process, this is tentatively where I am at the moment. So first of all, I think all these arguments for expanding global health security and the fact that they're affecting the workforce and those that work in policy in global health security is really important. But I think these arguments pose risks for both global health and global health security. For global health, we can see this perspective coming that this is, frankly, an immoral enterprise that lots of those working kind of humanitarian NGO sectors don't want to work within. So expanding this risks fracturing this already, I would say, strained relationship even more. And it poses risk for the global health security enterprise, as I was saying, as we lose the credibility of advocating for the Big Bang threat by trying to kind of cram too much into this definition and this framing. So because of this, I don't advocate for expanding the concept of global health security beyond these epidemic diseases. But I think what my argument shows, these arguments show, is that there are real problems that are both ethical and need addressing in the field. And so moving forward, so my next stage of my research is looking at these questions, how we can find opportunities for identifying shared priorities, values, and efficiencies between global health and global health security. And I just wanted to finish with one last quote. So I'll read it out. So in this West African country that has currently 6 laboratories that can do viral hemorrhagic fever diagnostics, so they can diagnose Ebola, but they cannot diagnose hepatitis B. So the approach I take is, okay, so that is what you're interested in. My interpretation of that is that the country needs to have a functional laboratory system. And if it has that system, it can respond and it can adapt to whatever the emergency is and try and leverage that interest into a health system strengthening approach. That's what I do. That is how I justify working with a term that can feel very protectionist sometimes. And I think this is a really inspirational quote. It's someone that's working within the system to reduce those inefficiencies, the aspects that just don't make sense. But my concern at the moment is that this is happening on an individual level. It's the individuals leveraging this power, but we need to think more system-wide. We need to break down those ethical barriers, the inconsistencies between the fields. And I think, yeah, I think I'm going to leave it at that. But thank you so much for your time.